Hello, everyone, and welcome back to Alert and Oriented RN, the podcast for nurses by nurses. Of course, I am one of your hosts, Luke, and I am joined by one of my best friends and colleagues, Tori. Tori, say hi to the people.
Hi, everyone. Welcome back. I'm so glad you liked us enough to tune into episode 2. If you did not hear the first episode, please go ahead and check it out. We talked about ourselves, did a little intro, talked about the current culture of nursing, what the show's going to be about. So it's really awesome. Go check it out. But I'll turn it back over to Luke. So Luke had a really good idea about doing a feel-good moment.
Yeah.
And I like that. So I feel like there's so much negativity going on in nursing. It's kind of nice to just have a little feel-good moment to keep us grounded, remind us why we're in the profession. So we want to start off probably every episode from now on with a little feel-good moment. So we'll start off with Luke. What was your feel-good moment for the week or the past couple of weeks since we last recorded?
Yeah, I mean, it's not nursing related. It's indirectly nursing related because it has to do with grad school. But my feel-good moment for the week is I just finished up my third year of grad school, submitted all my assignments and just got my feedback and got good marks. So passed, moving into my third and final year. Very excited because I worked really hard. So yeah, moving into this third and final year, fall semester, on a high. So
I'm
that'll
so
only last for a
excited.
couple days, I'm sure.
Oh, that's a solid feel-good moment.
Yeah,
right
it's always feel good. So what's yours?
My feel-good moment is, so I just came off of my 3-day stretch, and we had a little girl who was on ECMO for like 10 days and then intubated still for a while. But I had the privilege of getting to put her on room air.
Nice.
Finally, and moved her up to to a rehab unit essentially. So she's pretty recovered. I mean, it's a real good feel-good moment.
That's a real good feel-good moment.
When you get to
Every nurse out there that's listening to this knows the satisfaction of that, of seeing somebody that's struggled for so long that you put so much effort in. And even though they're leaving your care to another floor, it's still like, that's a happy moment. You're going to miss them, but hey, it's a step up and it's an improvement. So that's awesome. That's a good feel-good moment.
Graduating from the ICU is always a feel-good moment.
So yeah, that's a little segment we want to put into every episode just to kind of start everything off on good vibes. So everybody, feel free to write in, email, DM on Instagram, anything, you can DM both of us even personally, share some feel good moments. If you want us to actually share your name, we'll do that, but we want to read some feel good moments every episode, share it out there. Because like I said, as tough as this profession is, there's a lot of good things that happen too. And we want to share that and, brighten everybody else's days. So, going to be a cool segment looking forward to.
Yay.
Yeah. But, let's get into this episode.
What are we talking about today?
Yeah. So, we were thinking about what we wanted to talk about. We wanted to stay relevant to the profession, currently and how it is. And so we both came on and agreed that, let's move into nursing burnout.
It's the hot topic. Let's be real. Why are nurses leaving the bedside? 100%. And how many, what is the percentage of nurses that are actually bedside nurses? We were interested in that. We were talking about that because Luke brought up a good point. There's 3 to 3.5 million nurses in the United States, which sounds like plenty of nurses. You talk about there's this big nursing shortage going on. So essentially how many of those are actually bedside nurses? Mm-hmm. And so there was a study that we looked at. What was it? I guess it's a little over half of those nurses are bedside nurses. But so we also saw another one from the American Association of Critical Care Nurses in 2019. 58% of RNs do work in general medicine or surgical hospitals. So that was 2019. But another study that we looked at was also in 2019 said 33.5% of new RNs leave the bedside after 2 years.
Yeah. It's kind of, this is staggering. That's a third of new nurses leave after their first 2 years, which typically is their first nursing contract, right? Most facilities, if you get into bedside or acute care nursing, you do a 2-year contract. That's, 1 year of residency and then 1 year off residency. and then you're free to do whatever you want. Now, you don't have to re-up, but you know what I mean? You're kind of not locked down with having to pay back anything that you may have gotten as a bonus. But that's staggering. A third of new nurses every 2 years leave bedside.
And that was prior to the pandemic.
That's private. Yeah. So you got to think, if we look at numbers here a year from now, 2 years from now, is that going to be closer to 50%? 50% of new nurses are leaving, to where then now all of a sudden we're probably going to drop from 58% of all nurses are in a bedside setting to, less than that 50%, which again, that's staggering as well.
Yeah. So, I also wanted to just reach out to people, and I put a little Insta story out, and I was like, all right, who all has left bedside? I want to know. I have some friends. Well, we have some friends who we went to school with that we know are no longer bedside nurses. And I wanted to hear firsthand from them what caused their burnout. So this one comes from a nurse who essentially left the bedside to become a school nurse. And then now she left the profession altogether, and she teaches health science at a high school. And so she goes on to say that she just didn't feel supported, that the administration just wasn't there, that they would kind of show up and they wouldn't really advocate for them to have really good, safe patient, nurse to patient safety ratios. So she just felt unsafe all the time at work. And so she says that was the biggest contributor. She said that she got a little bored. She also goes on to, she wrote a nice little email, went on to say that she got a little bored when she was just a school nurse, because she just didn't really she felt like she was losing her skills. It wasn't as fulfilling. So she went back PRN. So she was working in the ER, maybe one shift a month or one shift every 2 weeks or something like that. And she says 1 12-hour shift in the ER is the same amount of mental and physical stress that the toll that it took on my body than the entire 3 months as a school nurse. So she said she would come off of 1 12-hour shift, and she felt like it was the same amount of physical and mental stress
as 3 months
versus 3 months as a school nurse.
I mean, that's crazy. And that's just one person's account, but it'd be interesting to see how many other people, if we put another poll out after hearing this, yes, if you agree and you feel the same way, no, if you don't, what the numbers of that would be. Because I can think of how I feel when I come off of a 1 12-hour shift, and sometimes it's like you got hit by a bus. But to sit there and say 1 12-hour shift in an ER, now let alone it's a busy ER, it's in a downtown metropolitan area, is equivalent of 3 months of a 5-day-a-week job.
I don't know.
In a school that's, let's say it probably at least, 1,000 kids. And now given, a lot of those kids obviously are healthy. They're at school and stuff doesn't happen, but there's still responsibilities that you have as a school nurse outside of just, if a kid gets injured or something like that. But that's crazy. Yeah. That's crazy. 12 hours for 3 months. So we're talking 90 days. 12 hours is the equivalent of 90 days. But then if you talk to other nurses, that's appealing. Because if you look at it from the flip side, you're like, oh, I can go work 90 days, a Monday through Friday job that still uses my RN, BSN degree or anything like that. And I get 3 months out of what I would feel after one day just in an emergency room. I see the appeal. Yeah.
On the flip side, I would be bored.
Yeah, and I don't think I'd want to work Monday through Friday.
I don't want to work Monday through Friday either.
Definitely. I enjoy full-time being 3 to 4 days a week. It's pretty nice.
Yeah.
Now it takes a full off day to really kind of get back.
It really does, especially being a night shifter.
Yeah.
It's just like, okay, you have 2 days off. Say I have the weekend off, like Saturday, Sunday, then I'm back on Monday. It's like, okay, I have to either stay up all day, which some people do, which I do not have the energy for that. I can't. I got to go home and take a nap.
Yeah, there's a couple hours.
So I take my little nap. I'll sleep maybe 3 or 4 hours, and then I force myself to get up. And just sometimes, like yesterday, I just got up and went and sat in the sauna. That was my workout and stretched.
There you go. So, yeah, you have to take care of yourself, and you got to do what's right for you, but it's okay. So I just can't get past 12 hours equals essentially almost 90 days. So then, so her big thing is she was overworked, and the other thing we always hear is underpaid.
Yeah, absolutely. So,
I mean, and it's not a surprise. You can look it up. It's almost everywhere. If you were to survey nurses, and there's plenty of them out there, and we look through it, number one contributing factor of nurses, they feel like they're overworked and underpaid for what they do. Mm-hmm. And I mean, it's maybe even more evident than now. I mean, hospitals are slammed. But guess what? There's still only 58% of those 3.5 million nurses working in them. So who's taking care of those patients? Overworked nurses.
Oh, exactly. Because I was talking to like a family friend, and, you know, all this stuff going on in the news that's just saying, oh, well, it's actually not, there's a shortage of nurses. So that's why the hospitals are full. And I'm like, no, that's not how it works. We've created units like out of thin air, out of like closets and abandoned floors. We're like, this is going to be a COVID unit. And guess what? We're going to find staffing for it. And we're just going to give you more patients because we've created more beds. It's not, and that's why people want to leave, because they just don't feel safe.
Yeah. I mean, well, it's interesting. So you said that. So I looked up a survey or a study that actually just completed not too long ago. It took place over March of this year, so a year from the start of the pandemic. And it surveyed a little over 1,000 RNs, so not a huge sample size, but a reputable healthcare organization that was doing, you know, something. And they surveyed a highly predominant COVID hospital, I guess you could say. Okay. And 50% of all of those nurses reported an increase in their workload. So patient ratio, that's workload for nurses is how it's looked at, of 2 to 3 more patients per shift.
Oh my God.
Now we work in peds. That's pretty evident if you listen to the first episode. Our biggest ratio for me is 3 to 1. Mm-hmm. Yours is typically 2 to 1. A lot of the times 1 to 1 in the ICU, depending on child. A lot of adult units are already potentially 4, 5, 6 to 1 patients to nurse. Add 3. Now you have 1 nurse taking care of 9 patients. Tell me how that's safe.
That's so unsafe. And it's not fair to the patient at all. It's not fair to the nurse. It's not fair to the patient. It's just ridiculous. And I think that's what really contributes to the burnout, is because the nurse is saying, who is taking care of me? Like, how is this safe? Administration comes in and they're like, oh, like, do you guys need anything from us? And I'm like, yeah, I need you to scrub up and join me. Yeah. When was the last time you were at the bedside? And I think that's why nurses get so frustrated, is because they just don't feel like anyone's advocating for them.
Yeah. Well, yeah, I mean, if you've ever been in a hospital and you've seen all the moving pieces, there's a lot of moving pieces. There's a lot of other departments that we couldn't do our jobs without, right? But if you just spend the time on a floor, you're going to see more badges that say RN moving significantly amongst the unit than anything else. And so then when you sit here and say, hey, what's the predominant reason you left bedside? I'm overworked. You know, for me, I wouldn't even say underpaid. I mean, for me, I mean, I love my job enough to where I feel like at times I am paid, you know, adequately or whatever, because I just love what I do. It's fine. It's not a money thing for me now. I mean, of course you need money to live life, but you're overworked. Okay. Well, then you ask, you know, Joe Smo down the street or whatever, that's just observing everything. And it's like, well, all I ever see on the unit is RNs. Mm-hmm.
I know. I always say that I need to be adding more things to my badge. I'm like, I need to put EVS worker, FNS.
Yeah, and it's not a knock to those departments, because those departments bust their ass.
Oh, they do
absolutely bust their ass, and they're understaffed too.
Yes, because
you know, as much as nurses want to leave the bedside, you think about some of these other departments and what they're asked to do in a pandemic, but just on a everyday basis before this ever happened. And if you don't feel valued or taken care of, or you're overworked, I'm not staying in this job. I can go find something that's probably equal pay, maybe a little bit. There's just like our friend who's like, I can go work 5 days a week. My mental health is so much better. My exhaustion level is near zero.
Yeah.
And I'm happier. I mean, and it's just crazy. So And so that segues in. So it's another big reason is and I just kind of touched on it is staffing, right? So we talked about, I don't think there's a nursing shortage. There's 3.5 to 3.8 million nurses in the United States. 58% of them as of 2019 were still in acute care bedside nursing roles. So there's not a shortage of nurses, because if you increase that to maybe 65%, you're maybe looking at a drastic different area there.
Right. More nurses at the bedside.
But when we talk, we talk about to other nurses and we reach out and we think about ourselves, another huge factor of why we get burnt out is staffing. And I just talked about it. This one hospital, 50% of their nurses reported a workload of 3 more patients. So, I'm just thinking about me. So if I got an assignment of 3 and I'm asked to take 3 more, now I've got 6 kids. Now, remember, a lot of kids, depending on age, don't function on their own. Surely, hopefully there's a parent there or a caregiver, and a lot of times there are. But if there's not, now I've got potentially 6 patients, all of an age, let alone what their prognosis or their current, acuity is, that some may not be able to use the bathroom, because obviously age or something like that, or their prognosis. We talked about that. Can't feed themselves, don't know how to entertain themselves. The other thing is a lot of times kids, and it's not their fault, but a lot of kids can't entertain themselves.
Yeah.
So now I'm trying to jump between 6 different rooms, entertaining a kid, making sure they're safe, let alone not pull out any of their important stuff that may be in their body. Right?
Oh my God, that's like an episode on itself.
Staffing. Yeah.
And then with the visitor policy now with COVID, it's all these visitor restrictions. Yeah. So it's like, I think, before the pandemic, we had like literally no visitor restrictions. You could have as many people in the room as you wanted, which was never, honestly, I hated that. I hated that because you'd have a kid that was there for like new onset of seizures, and then the entire family is there stimulating the heck out of this poor kid.
Well, not only that, you sometimes just don't have the room.
You don't have the room. You're in there. You're trying to assess the kid, and then you have little ones who are like crawling on the crib, and I'm like, get this kid off of my leg. It's not fair to the patient. There's just all this huge distraction, and then I'm like, hospitals are so dirty. Like everyone's gonna get sick, being here. So yes, it was always kind of nice having some visitors there because you knew that your kid was being looked after. Mm-hmm. In a sense. And so, I'd always tell parents like, hey, you don't need to call if the monitor is doing this and this because, whatever, because some parents would call out a lot. And that was another thing, was sometimes having too many visitors was not a good thing. They'd be hitting the call light for every little thing. And then here you are running back and forth. But I think that the shortage of staffing is just, I don't know, having like one nurse take care of 9 patients to me is just like mind boggling. Especially when you think about critical care, because we have some kids that are 2 to 1. Like there's 2 nurses that have to take care of this one patient.
Yeah, absolutely.
Because we had this girl, she was on CRRT ECMO, and that's a 2 to 1 assignment.
Yeah.
And then you think about the other critically ill kids that are on the floor that are vented, mm-hmm. and a lot of us are getting 2 vented patients. It's just insane.
And not stable vented patients.
No.
They're vented patients that constantly, you must adjust the vent based off of your assessment to keep them stable. And
some of them are not sedated very well. So you're there,
Exactly. But the other thing that's interesting about staffing is pretty well known, I would say, even if you're not familiar with how nursing works or healthcare, there are no off days.
No.
Nursing is a 7-day a week, 24 hours a day, 365 days a year job.
And never sleeps.
We're required to work a certain amount of holidays every year. Mm-hmm. We do get some flexibility depending on your unit, and everybody's practices and stuff are different about which ones you work. But that also could very well be if such and such beats you to it and they've already kind of filled up this many nurses asked off for this holiday. Sorry, you were the last one that came, or however, potential units do it, mm-hmm. You're going to work it. But also on top of that, we have to put our schedules in a month to a month and a half in advance. Well, patient census changes day to day, hour to hour. So now a shift that I'm scheduled to work a month from now, there might be twice as many patients on there. And we only thought we were going to need X amount of nurses because based off of what we're going, well, now we're down 2. I mean, I'll admit it. I mean, I'm very hesitant to pick up extra shifts, not because I want to see my coworkers drown or anything like that, but I have to plan out my life. I've got things to do. Like I said, I'm in school and stuff like that. So that's been a big proponent, but also at the same time, like I got to take care of myself. I need off days. People are like, well, you only work 3 days a week. Work over 40 hours most weeks in 3 days, where most people work it in 5 to 6.
Yes.
So, I mean, yes, I only work 3 days a week, potentially get 4 days a week off, depending on how my days fall. But I've covered 40, if not closer to 50, sometimes even more than that, to where it's like, it would be extra money. It'd be helping my coworkers out, which is the first thing that always pops in my head. Is like, okay, it would be better for all of my coworkers who I love if I could come in. But I have to take care of myself. Yeah.
How many text messages would you say you get like daily whenever you're off of work to ask if you can come in? Because I get one every day.
Yeah, I mean daily. You know,
I
they
get
send
them
out
daily.
a message, is anybody able to come in? And usually, sometimes it's even a couple of days in advance for a day in the future. But I mean, it's crazy. I mean, you talk about staffing and you talk about this increase in patient population due to the pandemic, and then you go back and you sit here and you realize a third of new nurses leave the bedside in 2 years. And you've been at bedside now for over 3.5. I'm pushing through my 4th year at the bedside. Don't plan on leaving. Hope to even stay there as a nurse practitioner. But so essentially the residency class that I came in with nationwide, a third of us are gone. And maybe even 2/3 now, because I've doubled that. So I'm over 4 years in. So a third left our first 2 years. Who's to say a third didn't leave after these last 2? It's crazy. It's honestly crazy. I mean, we could talk about this all day and stuff, and the whole point is to bring awareness to nursing burnout, which I know there's a lot of awareness out there, but
we also want to make sure that we're not always putting ourselves last.
Yeah,
because that's what we're trained to do.
Well, okay, so bingo. So it's interesting you bring that up, because this was the topic that I wanted to talk about when we got into burnout, because it gives me an interesting role to ask you purely based off of being a female in the nursing profession. So I read multiple studies, multiple articles, some done by psychiatrists, some done by nurses, doctors, all of it, reputable institutions, whether it was different state health institutions, national institutions, stuff like this. And I came across a very interesting one done in conjunction with a nationwide study, but it is a psychiatrist, I believe, or a psychiatry researcher. So she's now in more the research aspect, conducted a study that finished in 2019 out of the University of San Diego. That said one of the primary reasons that nurses leave the bedside in waves is because the profession is 85% female. So 3.8 million nurses in the United States, 85% of those are female. Not surprised. It was from the beginning, it was pretty much only something that females did. Males didn't look to it. But one of the main things that they said was they felt there was a dual burden put on them, whether it was by society or just decisions that they made. And what I mean by that is they have families at home, significant others, aging parents, or just are a caregiver for somebody else. So they sit here and says women who are nurses typically must balance a challenging job with caregiving duties at home, a co-author of the study wrote. The nurses I work with routinely face tougher challenges at home that place added stress on them, such as caregiving for children or parents. When you add in workplace and home stressors together, it's no surprise that nurses are struggling. So I must ask you, Tori, as a female, now you don't have kids or anything like that, but as a female, when you hear that, and still a very female-predominated profession, and so many nurses that do have families or are caregivers at home, does it surprise you?
Oh, it doesn't surprise me at all. It's insane. I mean, I always say I don't even know how some of my coworkers do it. Literally super moms, that have been working night shift. And I would say that a lot of, I don't know how you can do night shift and raise a family. It's you, because a lot of times I feel like you sacrifice seeing your significant other, your partner, because a lot of times you're switching off. Like, okay, I got them during the day. Okay, I got them at night. You're working all weekend, right? Yes, I'm working all weekend. Okay, so I have the kids all weekend, or the kid all weekend. And it's just, it's a lot of give and take. And I think that women traditionally are always the ones who are, cooking, do a lot of the housework, cleaning, taking the kids to daycare, picking them up. And a lot of that's really hard to do when you're working a 12-hour shift 3 days a week. Either way, when you look at it, if you do a day shift, 7A to 7P, I mean,
typically,
yes. Most kids, school, how are you going to take them to school? Because they're it's in a way, it's like they're too young to take the bus. Some of them.
Yeah.
Some parents don't want their kids to take the bus.
Yeah.
And then school doesn't start until like 8. And so you're there dropping them off super early. And then if you pick them up, they have to go to like after school care or something. You're picking them up at like sometime, 7A to 7P, but I've been getting out at like 9 o'clock, 8:30 most days. So you're going to leave your kid at the after school care for like 8+ hours when school is over.
Most after school care maybe only makes it to 5, 6 p.m. because that is the traditional work day, right? In the United States, most other jobs are done by 5 or 6. Mm-hmm. So you're only talking a couple hours of after school care. Now, if you've got sports and somebody can help and take. So, it takes a village. But what's so disturbing is essentially it's you leave work and the job doesn't stop.
It doesn't stop. You have to go home. You got to go home, take care of your family. And I think you really need to have, for me, I'll be completely transparent. This is the reason why I don't have kids yet. This is 100% it, because I really like my job. And I don't think that I haven't found a partner who I feel would be able to take on the responsibility of sharing that responsibility with me to raise the family. Yeah. Because you really have to have the man step up. Not saying that they don't. Dads are amazing, but traditionally, when you come home when the man comes home from work, like dinner is ready, the kids are playing, they're upstairs, whatever. And the things are taken care of around the house. And it's not like that in the nursing profession. Even when I have my day off, it's like, you spend it taking care of your family, which in a way people like, a lot of women like doing that.
Yeah.
Taking care of their kids. But it's a huge sacrifice. And you don't get to put as much into the bedside anymore as, like, I spend my days off. Like, I will go to a coffee shop and study. And like, if I took care of a kid that had a syndrome that I'm like, I'm not familiar with this, or I need to brush up on meds or brush up on this like syndrome, like I will go and study and just like chill for a little bit. Yeah. And I like doing that on my time off to like devote more time into my work.
Absolutely.
But you don't get to do that not always.
Not always. But, it's tough because, right. So there's always continuing education that comes with our profession. If you don't continually educate yourself, you will fall behind, and things will happen, and patients will suffer. But when do you find time if you have a family? My first boss left because she felt like she was missing out on too much of her kids' lives at a very fun and important, impressionable age. Mm-hmm. So she stayed within the nursing profession, but found a job where she's home more.
Yeah,
absolutely. Completely support that. Definitely support that. And it's weird because it's almost like the more that you meet people, right? And nursing is it's a fairly younger profession within the medical field that you can get into, right? Because you just need, typically a bachelor's degree, you can have an associate's degree. But so you're talking about a lot of people getting out after, 4 or 5 years of college. So you're talking in your young 20s when you get to start nursing. Whereas, medical school, it's well documented, 4 years of undergrad, 4 years of medical school, 4 to 5 years of residency, whatever. So you're pushing your early 30s before you actually are like, I am a full-fledged physician, provider, whatever. And, same thing with some of these rehab services that require you to get a master's or a doctorate before you ever actually provide care within that rehab specialty. So it's one of the younger ones. And so, the family thing might not be on everybody's mind at first. And, it's well documented that people are getting married later. They're starting families later. A lot of that is attributed to the society's push and the great push of women deserve to work and establish a career and stuff. You know, they don't just need to start having kids and have a family. That's awesome. Like, it's great. But it's weird because you sit here and you're like, you know what? It's almost like talking about Bigfoot when you talk about having a significant other in this profession that supports what you do and why you do it. I'm lucky enough. I have an amazing wife that, you know, school teacher. So Monday through Friday. And that's, I mean, what she does, I don't know.
I could never be a teacher. No, she's incredible.
It's crazy. And so, and it's not because the expectation in our house is that she do it. But she enjoys cooking, but she supports me to the point where on days that I work and I don't get home till 8:30, when I walk in the door, dinner is ready or it's almost ready. And then dinner time for us is our time. We either eat dinner and just talk about each other's days. How did it went? And he's, you know, sad and glads. We share a sad and glad. Or we just watch one of our shows that we love watching together. And it's maybe only a couple hours before we're like, okay, we both got to go to bed because I'm either back at the hospital 6:30 in the morning and she's back at the school and stuff like that. So our quality time together goes down. But the sacrifice and the support that I get is amazing. But most people don't have that. Right. And it's crazy. So it's no surprise that people are leaving, because if you do find that and you want that extension of your life to flourish, sometimes it's hard to stay in the nursing profession or to stay at the bedside role specifically. The
bedside is pretty demanding. Yeah, the hours are demanding. I mean, when you go home, you just want to sit and like relax. And, you know, it's like right now, this is what my routine looks like is I typically, when it's my first of my 3, I always do my 3 in a row. I always try it. That way I can be like day shift as normal as I could be, you know, for my days off. So I wake up at like noon or 1 on my first day and just like do chores around the house that maybe I didn't get to, and then hit the gym, come home, shower, eat, get ready, go to work. And then I get off probably typically average, I get out, come home, shower, I'm in bed by like 8:15, 8:30, and then sleep for maybe 5 hours, wake up at like 2 or 3 in the afternoon. And I like to get up and go to the gym and just be normal and like interact and talk to people. And, you know, and it's a good time to go because nobody's really there. It's a beat the 5 o'clock rush. But how do I fit taking care of a child in between that time? I mean, because I'm basically after my 3rd shift, you know, I would have to sacrifice something. Something's got to give.
Yeah. Well, it's the dual burden. You have to give up something that you have to continue to take care of somebody else.
Yeah.
It's
like now kids are in school, which is great. Yeah. But when they weren't, and it was the pandemic, and then you're a nurse and you're taking care of patients that are super sick, short-staffed, you come home, the kids are there. Like they want to be entertained. They're being homeschooled. Some kids are still being homeschooled.
Well,
they're doing hybrid.
How many times have we heard of colleagues and stuff like that? Well, when they wake up to start getting ready to go to work and you're getting the kids ready, all of a sudden kid A is thrown up and they're sick.
I know.
So now they thought they're going to school, daycare stuff. That's not an option anymore. Don't send a sick kid to school or to daycare. But now, okay, so who stays home with said kid? Oh, I got to call in. Puts more strain on your colleagues, the hospital, the staffing, or stuff like that. But you can't avoid it. Your kid's sick. You got to take care of him. I mean, some people out there, if they're want to be asses about it, well, you've decided to have kids. This comes with it. Well, you know what? They're allowed to have a life.
Yeah, exactly.
I mean, I hope to have kids. And I mean, I know that's going to come up. Now, the penny under the tongue trick, that's never going to work with any of my kids. I feel warm. Okay, well, let me do a full assessment on you. Let's actually find out if something's going on.
I know.
Oh, you just have a math test today. Gotcha. Okay.
You just got to do the Ferris Bueller thing with the hairdryer to the forehead.
Yeah.
That's the best.
Something. But so talking about nursing burnout, and we've only talked about 3 factors that attribute to it. And I would say 3 of the probably not the most important, but the 3 highest talked about reported things. With burnout and the nature of our job, what we see, what we do, what we hear, if we didn't talk about this, we would not be doing our job and we would not be supporting our nursing colleagues, because society, the profession, and I would say healthcare in general does not really advocate or allow for this to be talked about without kind of being looked down upon. And that's mental health. Mental health specifically of healthcare providers. And this is all together. It's not just this last year and a half. That's a whole different world, and it's still going on. So who knows what a couple of years from now is going to look like. But just to start this, and I want you to hear this, because I think it's going to make you, one, sad, and I think it's also going to shock you.
But it needs to be talked about.
But this was from a Physicians of Human Rights group. Okay. They wrote an article in 2021, and this is, a group of physicians nationwide. Mm-hmm. They wrote an article in May of 2021 about some findings they had found the beginning of this year, so 2021. This is just general population. 4 out of every 10 adults reported having symptoms of anxiety and depression, which is a 400% increase from January of 2019. 400%. So, wow. But then now what if I sit here and tell you that we saw a 30% increase of children ages 12 to 17 come into the ER for suicide attempts, and 24% increase in ages 5 to 11 just between March and October of last year. So the start and a good chunk of the pandemic. That's just the general population. So those are pretty well documented, right? Mm-hmm. I mean, we've come a long way in mental health advocacy for the general population, but we're not there for nurses. So now listen to this. Huge national survey, national study, mm-hmm. In a bunch of different publications. I found this one through JAMA. Conducted. Found that female nurses, when compared to the general population, are at a 50% higher risk of suicide or have suicide attempts. And 41% of male nurses have a higher attempt risk than the general population. So we saw a 400% increase in the last 2 years in the general population of experiencing anxiety and depression that can lead to suicidal thoughts or attempts. And then you sit here and tell me that 58% of female nurses and 41% of male nurses report being higher than that. Thoughts?
It's insane, It's so sad because it's like, we're advocating so much to the general public. And of course, I think we've done a really good job in the past 10 years as far as mental health awareness. But why nurses have nurses work in healthcare. They know all the resources. So why are they why are they committing suicide more? What's contributing to that? Why don't they feel supported?
I don't know. It's interesting because the same study sat here and talked about factors, and they concluded that there were no direct factors that they could attribute to these staggering numbers. Of course, we talked about some things that lead to nursing burnout, and of course those can be, but there's no direct correlation. There wasn't enough statistical evidence and everything that was this is exactly what it is. It was just dispersed, it was spread. Mm-hmm. They said, higher job demands, which we talked about, staffing, overwork, underpaid, mm-hmm. Potentially the lower autonomy when you compare it to physicians. And what that means is we carry out most of the orders or the care, but we're not the ones that get to make the decision. Mm-hmm. So when we talk about that, then and this might be something we touch on in the future because it's a thing for me, is a lot of times we're asked to do stuff that we don't necessarily believe in. And you can always say no, mm-hmm. but then there's a stigma to that. We'll talk about that another time. And we'll talk about it, but then the other one was the fear of the stigma. So throw some more numbers out here because, like I said, we want to be a platform of advocacy, talk about the things that people don't want to talk about because it's there. And we're also here. That study that I was talking about, one of the teams that contributed numbers to it, okay, concluded based off of they looked at 159,000 suicides that occurred during this 2007 to 2018, and then the report came out in 2019, right? So 11-year period. Nearly 2,400 of them involved nurses. And I don't have the percentage on that, but that's still a pretty significant number. Roughly 8 out of 10 of those 2,400 were women nurses, which kind of correlates because if you think about it, about 80 to 85% of the nursing profession are women. But 8 out of 10 women. And we talked about the dual burden thing and that primarily affecting women more. But then they sat here and they concluded that the incidents, right? Okay. They were able to hone in on an actual definitive number, incidents of actual deaths by suicide. Nurses was 17.1 per 100,000. So about 17 out of every 100,000 people was a nurse that committed suicide. Compared to general population, 8.6 per 100. Twice as many nurses per 100,000 people commit suicide than just somebody that's not a nurse. Twice as many. 2 times.
When you think about the things that we see, and I know that you touched on it, that more kids are coming into the ER for suicide attempts. You know, we see them a lot. We see them a lot at work. And, you know, having to go into a room and see a kiddo who thinks that their life, they don't want to live their life anymore, and they're 13. Their kids are getting younger and younger. You know, when I think about it, I'm like, okay, like a 17-year-old, a 16-year-old, you know, they have these suicide attempts. I mean, I've had kids who have like tried to make pacts with each other, and they do a suicide, you know.
Well, I told you 24% increase in ages 5 to 11 of suicidal attempt ED visits.
So when you think about what we have to see and then go home, it's awful because when you think about it, when you like as a nurse, when you talk about things with your family and they're like, oh, how was your day? Sometimes it's a little morbid and you're like, well, it was kind of rough. And I just kind of keep it general because it can be a real party killer. And we have to see that every day when we go into work.
Oh, but Tori, it's the nature of the job. It's what we do.
It's what we signed up for.
It's what nurses are. I mean, that's devil's advocate right there. It's the nature of the job.
Right.
So that's well, you work in the hospital. That's what they come there for.
Mm-hmm.
Bullshit. It's a stigma.
I know you'd brought up something earlier that I thought was really great. That there was a commercial that was out of this nurse and they're coding a patient for, I don't even know how long. And the patient passes away and all you hear is the flat line. And then you see the nurse turn around and wash their hands, all this stuff, and then take a deep breath and then just walk into their next patient's room.
With a
smile.
And
say,
energy.
hey, how can I help you?
Yeah.
And then when they get a complaint of, well, I didn't get my water fast enough.
Mm-hmm.
And it's real. And I think that happens a lot. Or you get the patient who was like, can I just have a turkey sandwich? Or the parent. And I'm like, I'm not here to take care of you. I'm here to take care of your sick kid. Yeah. You get pulled in 8 different directions. And emotionally, you're all over the place.
Well, it's a stigma, right? That's what everybody keeps saying. It's a stigma. Well, what is a stigma? It's the fact that you know what your job entails. People aren't going to always make it. Some people are going to be extremely sick. But you just have to deal with it. Mm-hmm. Guess what? That's your profession. But then the stigma part of it is I can't talk about it. Mm-hmm. So I talk about it. And I can talk about it with my coworkers. I can share. I can talk about it with you. You get it. And we can let it out. But Can't talk about it with anybody else.
You can't. And some people get offended.
Well, and the rest of society almost kind of makes us suppress it down. And it's even more evident here with what's going on, right? And we kind of talked about it last week in the culture of nursing, and it led into the pandemic and stuff like that. But it goes back to when I had mentioned that I can't stand when people say, that's what you signed up for.
I know.
That's the stigma. That's what we're talking about. Why can't I talk about it? I didn't sign up for a pandemic. I didn't sign up for a job where, patients are passing away one after another. I know that came to be a part of it. I know it is. And you learn coping mechanisms, and you learn how to deal with that because you know it is a part of the job. Mm-hmm. We're not blind. We get in this profession knowing that's the thing. That's why they train us to be able to save lives. And we do a pretty damn good job of it. But the stigma that I can't talk about it is just like, well, that's what you signed up for. Mm-hmm. Cool. I mean, and it's interesting. You talked about that commercial, and it's funny. So I didn't even think about it. I mean, that commercial hit home with me when I saw it, and I was like, man, that's evident in any part of the nursing profession, especially in the hospital setting. So, but for me, it hit real close to home being in pediatric oncology. Now, I said last week and in my introduction, we win a lot more than we lose. And that's the beauty of it. It's amazing. But we do lose. And I can't tell you how many times I've walked out of a room that just crushed me, mm-hmm. to turn around and walk back into another room to a beautiful smiling face of a kid that's happy. And I have to be too. And that's a continuous cycle for 12 hours, mm-hmm. 40 hours a week, 365 days.
Well, because it's interesting you say that too, because most police officers, firefighters, yeah. If they witness a death, they get to go home or they get a day off.
Yeah. That's not everywhere, but
it's not everywhere. But there's some, and like there's people who I've talked to that have confirmed that, yeah, mm-hmm. that is a thing. And it's not for us. No. I mean, we'll literally code a kid, yeah. Do postmortem care. Yep. You have to consult the family. Yep. And you feel like it's your fault that, I could have done more. You feel like you could have done more. Could have done more.
We beat ourselves up. We do. We physically and emotionally and mentally destroy ourselves.
And then we don't get to go home after witnessing that and then like almost tearing ourselves down. We don't get to leave. You have to go home, and sometimes you get an admission, or they're like, can you just stay and be helping hands on the unit? And I get it. But that's just
that. You don't even get to go into the break room for longer than maybe 5 to 10 minutes or something just to gather yourself, right? And this could be, not that any patient is different than others, but this could be somebody, especially in the nature of our job, that we've known for months.
Oh, years. Yeah. You build a connection with them, yeah. And the family, and
it's I don't know. It's just somebody has to talk about it. We're going to talk about it.
It's not meant to be depressing. And, I actually went on a date with this guy, and he was asking me about my job. And so I was like, okay. And like, I didn't get into the nitty gritty, but just told him a little bit about it. And I barely I didn't even get into the nitty gritty about what we do. And looked at him, and he looked at me like I was crazy. Yeah. Well, and he was like, they're not in it, he goes, wow, thanks for depressing me.
Yeah.
And I was like,
well, and see, that's exactly what I'm talking about. One, I don't expect them to get it.
I don't
expect them to get it, and they never will.
No.
But I don't want people to continually sit here and tell us that we have to just deal with it, suppress it down, hold it in, because guess what? That's going to lead to burnout. That's going to lead to mental health disparities,
and it's going to
lead to more and more suicide.
Yes.
So these numbers are 2000. This report came out in 2019. So this was based on an 11-year study from 2007 to 2018. It's a significant amount of time, and healthcare has been crazy. I mean, you name it. There are no numbers yet for what we have gone through since March of 2020. We're still in it. So 17 out of 100,000 suicides were nurses, twice as much as the general population. And those numbers stopped. They collected it all the way through 2018. I don't even want to see numbers that come out 11 years from now that are going to include what we are currently going through. I don't want to see it. It already makes me sad. But at the same time, I want to talk about it now because I want to potentially affect those numbers being lower than they probably will be, because I want to talk about it. And that's why we're here. We're a platform to talk about what nursing is, what we do, what we have to deal with, but also know that we listen. We go through it too. Share it with us. We get that the general population isn't necessarily going to understand it, but at the same time, general population people, if you are listening to this or you're a loved one of a nurse, we don't expect you to get it. We just want you to listen, and don't tell us that it's okay or it's part of the job. Just listen, because you know what? Like, if you listen and you affect the numbers 11 years from now, guess what? You're an incredible person. And that's not to say that other people aren't incredible people, but I mean, I love my profession. I love my coworkers, and I genuinely love people who have a heart to be nurses. And it breaks my heart to sit here and see that both male and female are almost, female, yes, and male close, but both of us, and that's what's great about this podcast, male-female perspective, that both of us are almost in a 50% higher risk of suicide than somebody who's not a nurse. That's sad. That's sad. And I mean, it's not to be down. And of course, if you're struggling and you don't think you have an outlet, if you want to reach out to us, reach out.
Talk to someone. Don't hold it in. Don't hold it in.
And we also wouldn't be doing our jobs and caring for everybody if we didn't mention, the National Suicide Prevention Hotline, 800-273-8255. But we get it. We're nurses. We're in it. We deal with it too. And it's not okay that we have to deal with it, but at the same time, it's also not okay that we can't talk about it, that you can't share with people. And that's what it's all about. That's why we do what we do. That's why we wanted to start this. If you reach one person, that's one less person. And then hopefully that snowball effects.
And I love
helping multiple people.
I love what you said, where you talk about, if you're a loved one of a nurse and you're listening to this, which I think is great, because when you confide into somebody, you want it to be your partner. You want it to be someone who you love, a family member, whoever. And the times that I have shared things with my family, I'm like, I really don't want you to offer advice.
Yeah.
Don't offer advice. I'm just venting and I need to get it out. Yeah. And so I just, sometimes I'll tell them things, and sometimes I'll be very upset when I call them or tell them, and they're like, I don't have anything to say. And I'm like, I don't want you to say anything at all. I really just want to I just want you to listen, and I want to be heard. And that's it, is you guys want to be heard. We want to hear you guys. We want to hear stories. We want you to share your stories. Please write into us about any sort of instances, whatever. If you just want to write into us, say like, hey, I just want to vent about this incident that happened at work and I'm really upset about it, we're here.
Yeah. Or even just, hey, thanks for talking about it. Thanks for talking about it. That's all you have to say. It's just, hey, thanks for talking about it. Thanks for bringing it up. I'm glad somebody's saying it. And, if it helps you, great. So, two pretty heavy episodes to kind of start off, but again, you want to be relevant with what's going on, and that's why we do it. But another awesome discussion, I think. I love talking to you about this stuff. Both the passion that we both have for this is amazing, but, yeah, guys, episode 2. A lot of fun, heavy topics need to be talked about, but man, I can't wait to just continue this podcast thing. It's awesome.
Yeah.
Just have these discussions.
Thanks for listening, y'all. Yeah. Thanks for your support. We're here to support you guys. So it means a lot when you guys tune in and listen, and then hit us up on Instagram, all that stuff. So we really appreciate that. We love it.
Email us. We have a YouTube channel now, Alert and Orient RN on YouTube. Subscribe. That's where we're going to be uploading these videos. Just in case you want to.
Ooh, if you want to take a gander at our faces.
Yeah. And somebody go, what's the voice behind the face? Yes, Luke doesn't always have a mustache, but he has one right now, so.
Yeah, Caitlin didn't know that was going to be
but it's always fun. What's Luke's facial hair going to look like this episode? Yeah, we'll play that game as we go on.
I don't think Caitlin's going to want that.
Because it'll change. No. Maybe I'll wear a costume sometime. Who knows?
Oh, my God.
The Halloween edition. I've got plenty.
So like and subscribe. Follow us on Instagram, Alert and Oriented RN. We are ANO times 2. Thank you guys for tuning in.
Peace.
We'll see you next time.